Thank you for the introduction. I would like to thank the organizing committee and also the Elekta for inviting me here. It's such an honor. As the introduction, I'm from Gangnam Severance Hospital in Seoul, Korea, and we've been using Elekta's Unity MR for 2 years. And today I would like to share with you my experience and possibly the indications that might benefit from MR treatment. We were all probably aware that there's a limitation in conventional CT-guided radiotherapy, which includes the inability to do real-time imaging guidance. The pre-treatment community will show relatively well the tumor contours and also the organs at risk contours. You could actually take the community during irradiation, but this will be the result of the imaging. The MR guidance is a new technology. It's one of the most advanced MR imaging guidance technology. And Elekta's Unity MR combines the 1.5 Tesla MRI with the O-ring type linear accelerator. This figure in the bottom, the Unity MR linac, and you can see the large electromagnet in the center, and then it's surrounded. There's this linear accelerator rotating around the magnet. Combining the electromagnet or the MRI with the linear accelerator wasn't feasible in previously. However, the new intervention, the new development is there's a zone of minimal magnetic field in the center. This is where you can deliver the treatment of radiation. So this is actually the first patient that we took the MRI with on Unity MR. This patient, actually, I was treating the patient with the first HD, and you can compare the Chromium CT with the 1.5 Tesla MRI. MRI shows I guess this is a good example for the patient showing the clear margin of the tumor itself as well. And the MR also allows you the cine imaging for motion monitoring, and this image is taken during the beam radiation treatment. The workflow is a little bit different. This everything that happens in this rectangle is at the treatment room. So after imaging acquisition, after image acquisition, we'll decide whether the fractional variability or the motion is acceptable or not. If it's acceptable, we'll go ahead with the treatment with the adaptive position. This is mainly a re-optimization of the treatment plans. However, if there's a significant variability, then we go ahead with the recontouring and then replanning of the treatment, mostly with the adaptive shape. This is the online replanning with the patient on the treatment couch without moving off the table. So that was a brief introduction. I would like to share with you my experience in the past 2 years. I'm from a small, medium-sized radiation oncology department in Korea. We have 3 treatment machines: 1 tomotherapy, first HD, and then Unity, and 1 CT simulator. We have 3 radiation oncologists. Previously, we had 2 tomotherapy machines, 1 first HD. We replaced one of the tomotherapy machine with the MR linac. So the decision to introduce MR linac in our institution was made back in 2019, and our initial plan was to start the treatment in 2020 and early of that year. However, we all remember that there was a COVID-19 pandemic, and then there were quite a few delays and problems, and we ended up started treating the patient in August of 2021. This graph shows the monthly treatment or the number of patients we treat each month. And at the beginning, I guess we kind of explored how many patients we can actually treat. And the largest we ever treated was 32 patients a day. This is mostly with the adaptive position, no recontouring or replanning. But now we're currently treating approximately 20 patients per day, quite comfortably. About 5 to 10% of patients will undergo online adaptive planning. This now slide shows the treatment sites that we're treating. I'm not dedicating MR-Linac for a certain treatment site. If I see a patient who may benefit from MR-Linac, I will go ahead with the MR-Linac treatment. So when there is a patient will be for us, it's prostate cases. Half of it is definitive intact prostate cases. We also have treated a lot of adjuvant or salvage treatment. And we have about 1/3 of the breast cancer cases. These are mostly the tumor bed boost cases. And we also have a significant number of liver cases. We do treat MR-Linac with the conventional fractionation, but the number is decreasing. We're focusing more towards the hypofractionation, and here the moderate hypofractionation is mostly the prostate cases. In terms of the treatment time, there's no recontouring required, and everything is done smoothly. With the prostate case, we do sometimes finish treatment under 30 minutes. If there's recontouring required and then SBRT, it may go up to about an hour, door to door. So the first ever patient we treated with MR-Linac was a prostate definitive case. And prior to acquiring an MR-Linac, we treated prostate cases with tomotherapy, where we use the rectal balloon for rectal immobilization. Prostate immobilization, rectal sparing. With the acquisition of MR-Linac, we moved towards the moderate hypofractionation schedule. And this is the patient we treated prostate and also pelvic lymph nodes simultaneously. In this case, we do first visit registration for pelvic lymph node areas. And then if the recontouring or replanning required for the prostate organs at risk, we go ahead with the adaptive shape. The online recontouring, we do quite often with the adjuvant or post-operative cases for prostate. So you can see that this is the image diffused in the MIM software. If the bladder volume increases, sometimes there's a change in the position of the rectal wall or the bladder wall. So we'll be near the pelvic diaphragm, there's not so much change, but as you move up to towards the bladder dome, there's a significant change, especially the posterior part. So it will require recontouring, and this will be done online with the patient on the treatment table. Currently, the CNA-MR images, after the treatment, it's stored in a binary file. So we asked our medical physicists to be able to actually transform the binary file into the DICOM file so that we can register on MIM images and MIM software, and then we can actually use it for recontouring, replanning. So this is the typical offline recontouring and replanning process where we use the CNA image fused with the pre-treatment MRI, and then we'll recontour and replan. So I will share with you the cases that we've treated, and these are the cases that might be beneficial when you're using MR-Linac. So this is actually the re-irradiation case for locally recurrent prostate cancer. The patient actually had a surgical resection and also adjuvant radiotherapy. And then we had to deliver the re-irradiation in hypofractionated schedule. And in diagnostic MRI and pre-treatment MRI on ambiguous MR-Linac, you can see clearly the recurrent gross tumor. And I believe it was 2 millimole around the recurrent tumor, so the patient had tolerated treatment quite well. Occasionally, I use MR-Linac for MR simulation as well. This is the salvage case. With the salvage radiotherapy, I prescribe 2.4 Gray times 24. But if there's gross recurrence, I would treat with the boost treatment of 3 fractions. However, this patient has actually a large tumor, the recurrent tumor. So initially, I tried to deliver 4 fraction boost treatment. However, at the end of the 24th treatment, I described the MR simulation, then it showed the reduction in the tumor. It was almost near complete remission. So I went back to the 3 fraction booster treatment. And we're acquiring large amount of MR MRI data. So we use it for further studies, and this where I use the cine images and cine MR images and pre-treatment MRIs to determine the smallest PTB margin, the smallest safe PTB margin for prostate cancer. So with these images, I was able to determine the internal margins instead of margin interval variability margins. So the Benford formula, we were able to determine the PTB margin. And with this result, I was able to reduce the PTB margin around the prostate. We acquired the PSMA PET-CT about a year ago, and this is an ongoing study where we combine the PSMA PET-CT with the MR treatment. And PSMA PET-CT will localize the active tumor, and then MR linac will be able to reduce the PTB margin. So we're still gathering the data from this study. You may be aware that 1.5 Tesla MRI will be more effective in reducing metal arc effect. This is a patient with the hip replacement quite a while ago, so the implant was not MR compatible. So when we actually took the MR linac imaging, I was surprised that I was able to see the margin of the prostate bed as well as the rectum. This is an interesting case. It's I treated this patient with hyperreaction. It is scheduled for urothelial carcinoma. Our urologist actually removed the tumor surgically through a ureteroscope. However, he was only able to approach the upper part of the renal pelvis because of the acute angle, he was able to reach the lower part of the pelvis. So I was asked to treat the lower part of the pelvis, and because the patient had a compromised renal function, I tried to spare the upper part of the kidney. And you can see the 4D CT imaging and also the real-time cine MR images here. We also treat quite a few rectal cases for preoperative short course radiotherapy. This is by one of my colleagues. This is a setting that we use for liver tumors. So I use the abdominal compression belt and 4D CT imaging to determine the internal target volume. We still use the ITV because automated gating is not available yet, and I add additional margin for PTV. This is a recurrent hepatocellular carcinoma case where I treated initially with MR linac treatment and also followed by delayed boost. So the patient had a surgical resection and had a 5-centimeter recurrence in segment 7. Because the tumor was quite close to the bowel, I was treated with the 4.2 rate times 10. And after 3 months follow-up, the tumor was reduced in size, and also the tumor was close to normalization. However, we still had a residual tumor, and so we decided to deliver boost treatment. And after the boost treatment, it was below the normal range I mentioned that the tumor marker was. And this is the outcome or the initial experience I presented in Faro Postural last month. And we treated 31 patients with hypofractionated schedule with MR linac, and most patients received the 10 fraction treatment. The focus was the reduction in the tumor, the PTB margin. We initially treated the patient with 5 to 7 millimeter margin added to the ITB. Now it's reduced to 3 millimeters. And with the 6-month follow-up, we haven't experienced the local recurrence yet, and the patient could tolerate the treatment really well. This is a setup that we developed for a brain tumor cases, and this is an in-house immobilization device, and we're treating brain tumor cases with this device. One thing I wanted to point out with this case is that usually we use the immediate post-operative radiotherapy and use that image to contour the target for post-operative brain tumor cases. However, there's a significant delay before the patients start receiving the treatment. So you can see that there's a difference in the immediate post-operative MRI And this is the pre-treatment MRI delivered on the first day of the MR treatments. And you can see that there's a change in the tumor cavity and also peritumoral edema. So we had to use the offline adaptive planning. And this case is interesting. It's a rare case of optic nerve sheath meningioma, and I targeted the entire right optic nerve for PTB. Initially, I treated the patient with the pre-treatment MRI and post-treatment MRI. There's no change or difference, so I thought it was a safe treatment. But however, in the 8th fraction of the treatment, we developed the cine image sequence for brain as well, and you can see that the patient was treated with her eyes closed, but the eyeball and also the optic nerve was moving. And the patient wasn't aware of her eyeball moving. So after finding this fact, we told the patient to open her eyes and focus her eyes to an image that we provided. And the treatment of the cine MRI shows almost no movement. I mentioned the breast tumor boost with MR-Linac, and you can see that the CT-based target contouring is in yellow. And when actually we treated the patient on MR-Linac, the target contouring was inaccurate. So we had to change the target contour, and then there was a reduction in the target volume. And we also treat the patient with the image guided during treatment. I'm sorry, the cine image during treatment. When the tumor is constantly moving, it's difficult to recontour. So in those cases, usually the recontouring or the replanning is through either reducing the tumor margin or increasing tumor margin. So this was the case with for the single lung metastases. And with the 40CT image, I was able to give 4 millimeter margin to the ITB. And the patient actually did a lot of respiratory training even at home. So on the day of treatment, I could see the movement was much smaller, and I was able to reduce the tumor PTB margin for this patient. Another case for MR simulation. This is the case with recurrent papillary carcinoma. The patient had an early recurrence in the abdominal lymph node as well as the peritoneal seeding. The recurrent tumor was quite stable for a while, but when the tumor started increasing in size, the patient was referred for radiotherapy. But because the patient had a compromised renal function, the patient was followed with a PET-CT follow-up. So I used the diffusion-weighted imaging for MR simulation. I was surprised that the DWI image actually showed clearly the recurrent tumor. And this is another case treated by my colleague. It's showing the seeding tumor from the ovarian granular cell tumor. And when she used the pre-treatment MRI and post-treatment MRI, there was a displacement in the tumor. And we realized it was due to the increase in the bladder volume during treatment. So this will be an ideal case for the online recontouring, replanning, and treatment with the motion monitoring. So to summarize, the Elekta's Unity MR Linac combines the 1.5 Tesla MRI with the IMRT linear accelerator. So it has a superior soft tissue contrast and it has a motion monitoring capability. So with this real-time imaging guidance and motion monitoring will allow the reduction in PTB margins, which could lead to the reduced toxicity and improved tumor control. And not just us, I think most of the centers are using the MR guided radiotherapy for hypofractionated or SBRT cases. And we also have to remember that MR simulation can be an effective tool because it can be readily used for patient and show the current status of the treatment area. There are some issues to be resolved. I understand that the automated gating is coming for Unity MR Linac. 7 should IMRT should be updated to upgraded to a pre-med treatment. If there's treatment site specific MR coils, I believe the imaging will be much improved in terms of quality of the images. I think a lot of countries are facing the reimbursement issues, and currently in Korea, there's no reimbursement for MR guidance. So my colleagues and myself and Elekta Korea are working very hard to add the additional reimbursement. Thank you very much.